for scanning breasts, women's breasts, and it is a modality which is superior to other modalities in detecting breast cancer at a very early stage, because it is able to even detect the microcalcifications, because cancers of the breast, they start with just very minute calcifications in the breast, which you may not actually know because they are not painful at all. Something might be growing up in there without your knowledge. So, and if you are a person who does screening, like maybe once in a year, you can actually detect these, you can actually see these microcalcifications before you even get any symptom. And mammography is a modality which is the best in that. Those microcalcifications cannot be seen on the ultrasound, cannot be seen on the MRI, can't be seen on the CT. It's only mammography that can do that. So it's a special modality, and to operate it, you really need a good technique and a good experience. You cannot just go do it and then go start operating mammography. You need to work with someone before you are independent to work alone using that modality. It is somewhat unique when you compare it with the other imaging modalities. So sometimes it is called soft tissue radiography. It is a radiographic examination of soft tissues, and it requires selected techniques that differ from those used in conventional radiography. In conventional radiography, this radiography that we know of, the subject contrast is great because of large differences in mass densities and atomic number among bone, muscle, fat, and lung tissue. So in conventional radiography, for it, you can use it to image other body parts, because other body parts have very big or large subject contrast differences. For example, if you compare a bone and soft tissue, a bone is so dense compared to soft tissue. So with conventional radiography, you can clearly see the difference between a bone and soft tissue. But when you use conventional radiography on the breasts, you cannot see a difference. You can't see any difference, because a breast does not have any bone. It is just composed of fat, muscle, those glandular tissues, which are almost close. They have densities which are almost close to each other. So it becomes very difficult for conventional radiography to detect these almost similar difference. I mean, almost similar densities as different. It can't work with conventional. But with mammography, it is very easy to bring out the differences between muscle, fat, and other tissues within the breast, much as their densities are somewhat close. That's why I said it is a very unique modality. In soft tissue radiography, only muscle and fat are imaged. In mammography, it's only muscle and fat that are imaged. These tissues have similar effective atomic numbers and similar mass densities. The differences between them is very, very small. You can even neglect them. You can even neglect the differences. But mammography is a unique modality that can bring out such differences. So soft tissue radiography techniques are designed to enhance differential absorption in these very similar tissues. The soft tissue radiography, that is mammography, it is designed to enhance differential absorption in these very similar tissues. So mammography is categorized into two. There is screening mammography and it is also diagnostic mammography. Screening is performed on asymptomatic women, women that don't show any symptom of any disease in the breast, but they have just gone to the facility to do screening just to verify whether there is anything or not. And they can use a two-view protocol, maybe cranial cordo and the medial oblique, just only two-view protocols, just to detect unsuspected cancers. Just to see, like to detect when it is early. You go there, of course, when you know that you don't have anything. But you never know. You might detect something that you never expected. Diagnostic mammography is performed on patients with symptoms, patients that have come with symptoms. Maybe they have pain in the breast, or they feel some lump in the breast or anything. So 2 or 3 views of each breast may be required. You can do many views to ascertain the presence of any disease in the breast. The American Cancer Society recommends that women perform monthly breast self-examinations to themselves to check for lumps, thickening of the skin, or any changes in size or shape. Then screening once a year. Women, you should do screening once a year. Just, you never know. So the mammography imaging system, mammography became clinically acceptable with the introduction of molybdenum as a target and a filter and single emulsion screen film image receptor. I know you have been doing that assignment which I gave you for the screen film radiography. You realize that the films which are used, they are double emulsion for conventional radiography, but mammography, if it is for the screen film radiography, they use single emulsion. It is for a purpose. You can read more about it and know why. Mammography system is a very unique equipment because it uses different targets and filters actually. Conventional radiography, normally the target which is used is tungsten and the filter that is used is aluminium. When it comes to mammography, they can either use tungsten, molybdenum, or target. And then the filters can either be molybdenum or rhodium. Most of the modern mammography machines, they come with all these targets. You can find a system having all these 3 targets, the tungsten, the molybdenum, the rhodium. And they have both of these targets, the molybdenum and rhodium. So there's what we call target filter combination. This target filter combination in mammography plays a very important role because, first of all, breasts differ in thicknesses. There are ladies without breasts, others with some thin breasts, others with medium-sized and large and extra large. So you cannot use the same target filter combination on all these breasts, on all these sizes. The size determines which target filter combination that you're going to use. The moment you compress a breast on its breast support, the system reads the thickness and then selects the target filter combination automatically that it can use to bring out the perfect image of this breast. Anyway, we are going to see that as we move on. We also use a grid in mammography, because you know the importance of a grid is to eliminate scatter. And mammography, we really need a very good image quality. So these things should be done to bring out that quality. The breast is always compressed. The breast is compressed during imaging. There are many advantages why the breast is compressed. We normally use high frequency generators. You remember our first lecture for the generator, which was about, the second lecture, which was about the X-ray generators. High frequency have many advantages over others. And we have what we call automatic exposure control. This automatic exposure control is there to terminate an exposure the moment the appropriate image quality has been achieved. Any equipment that has automatic exposure control limits you on the technique factors you choose. In most cases, if you choose to use automatic, the only factor you choose is KV. The only factor you choose is KV. MA you don't choose. So when you choose the KV and then you make an exposure, then the automatic exposure control will exposure at a time when an appropriate image quality has been achieved. So there is no choosing of milliampere seconds. Automatic exposure control is for the machines that are fully automatic. They limit you on choosing which factors. But of course, you can also deactivate it and go manual and you put in the MA. But if you don't want, you activate the auto, you just put in the KV, then the exposure is terminated by automatic exposure control when the desired image quality has been achieved. So that means the automatic exposure control controls the MA and time of exposure. Now, imaging systems are designed for flexibility in patient positioning, and they have a compression device, a low ratio grid, automatic exposure control, and a micro-focus X-ray tube. Then the conventional radiography, the targets, the focus spots, which are used in the conventional radiography, one has a size of 1 millimeters, and another one has a size of 3 millimeters. Mammo have micro focus they have micro focus spots. One is a 0.1 millimeter and another is 0.3 millimeters. So a mammo machine looks like the way you see it in this image. The X-ray tube is always overhead around there. This is the compression device. This is a breast support, as well as a target, a detector. So the breast is always put in between and then compressed to the detector. You can use these compression pedals you see down here to lower this compression device and then compress the breast. Somewhere, or it can be having a screen here or down here to show you the thickness of the breast that has been compressed, and also the compression force that you have used. So high voltage generation, mammography imaging systems incorporate high frequency generators. So such generators accepts a single phase input. So that voltage is normally rectified and the capacitor smoothed to produce a DC voltage waveform. Remember these things in generators. So the DC power is fed to an inverter circuit, which changes the power to high frequency, and the high frequency generators are smaller and less expensive to manufacture. So they provide exceptional exposure reproducibility. Very small. Remember when I told you that they are small, light, inexpensive to manufacture, and then they normally come within the protective housing. You may not even see it. Okay, target composition. Mammo X-ray tubes are manufactured with a tungsten, molybdenum, or rhodium target. For tungsten, in machine operated at 30 kilovolts peak, Bremsstrahlung X-rays predominates, and only 12 kiloelectron volts L-shell characteristic X-rays are present. Remember, with tungsten, the K characteristic X-rays can stand at 56 kiloelectron volts. But here, because we are using a low KV, that is 30 kiloelectron volts, we cannot produce K characteristic X-rays. We only produce L characteristic X-rays. And those L X-rays, they have very low energy. 12 kiloelectron volts is very low energy, cannot even penetrate a breast. The energies which can penetrate breasts, they range between 17 kiloelectron volts to about 24 kiloelectron volts. So that's why we use low KVs. Low KVs. In mammography, we use very low KVs. The maximum can be 35 kiloelectron volts, and that is for maybe an extra large breast. But most of the breasts around 25, 30 there. KV that is used. These L-shell X-rays are all absorbed and contribute only to patient radiation dose, not even to the image. The X-rays useful for enhancing differential absorption and the contrast in mammo are those in the range of 17 to 24 kiloelectron volts. That is the range of energy that can bring out contrast in breast tissues. Lower than 17, no absorption, no image. I mean no penetration, no image. More than 24, very high penetration or more penetration, and you lose contrast, or you lose seeing the differences between these structures in the breast. The tungsten target supplies sufficient X-rays in this energy range, that is 17 to 24, and more above and below it. The 26 kiloelectron volts peak emission spectrum from a molybdenum target tube filtered with 30 micrometer of molybdenum, you note the near absence of Bremsstrahlung X-rays. That is the illustration on your right. That spectrum has been produced by a molybdenum target, like the spectrum of X-rays is produced by a molybdenum target, filtered by a molybdenum filter. Now, I should tell you that before filtering, this spectrum is like this. This spectrum is like this. It has to stand at 26 because that is the maximum, that is the KVP that is used. So it has to stand at 26. But now, when they inserted molybdenum filter, it absorbed the low energy photons and also suppressed the high energy photons. You can imagine, like, how can it really remove high energy photons? That is a question you need to ask yourself. How is it able to remove high energy photons? Because we have been knowing that the filter is there to remove low energetic photons. But now this one also suppresses the high energy photons. Why? The reason is, there is what we call, in science, there is what we call KH, the KH. The characteristic, I mean, the electrons in the K shell of molybdenum have a binding energy of about 20 kilo electron volts. I repeat, the electrons in the K shell of molybdenum, they have a binding energy of 20 kilo electron volts. What does that mean? X-rays sorry about that. So I was still explaining about the KH. Now, these electrons, because of their binding energy, which is about 20 kilo electron volts, it means that any X-ray photon that comes with such amount of energy or slightly higher is going to be absorbed photoelectrically. Do you remember photoelectric effect? For example, in photoelectric effect happens when an X-ray photon comes with the energy equal or slightly greater than the binding energy of that electron. It becomes completely absorbed. So within this range of 0 to 26 kilo electron volts, some photons that have energy equal to 20 and slightly greater, they can become absorbed photoelectrically in the filter. Members, is that making sense to you? I don't want to go away from this when you haven't understood that. Okay, all right. So that is the reason why higher energy photons can also be suppressed. The low energy photons are absorbed in the filter, but also the suppression of high energy photons. So this one, we normally use a molybdenum filter when we want X-rays in the range 17 to 19 kilo electron volts. This is normally used for small to intermediate-sized breasts or to medium-sized breasts that don't want like higher energies. So 17 to 19 can be used on the thin and medium-sized breasts because they have ranges of energy between 17 and 19, which is appropriate for those sizes. Okay, then again, we have another graph on the right. The 28 kVp X-ray emission spectrum from rhodium target filtered with the rhodium appears similar to that of molybdenum target. Yes, it appears similar, but there is a difference if you look at them. Because, so if we didn't, this could be the low and also the high are suppressed. When you look at it, you realize that suppression is somewhat higher than what we saw in molybdenum, because in molybdenum, the suppression was at 20. The suppression of higher energies was at 20 with molybdenum. But with rhodium, the suppression is at about 23, 24 kilo electron volts. This is responsible for imaging thick breasts that need energy range between 20 to 24 volts. Between 20 to 24 kilo electron volts can be used to image thicker breasts. So there we use rhodium as a filter. So Bremsstrahlung X-ray are produced more easily in target atoms with high atomic number than target atoms with low atomic number. Do you realize that with the rhodium and molybdenum, rhodium produces more Bremsstrahlung than molybdenum? These are all Bremsstrahlung for rhodium. Bremsstrahlung X-ray, these are all Bremsstrahlung for rhodium, but look at the Bremsstrahlung for molybdenum. They are very few. Why? Because rhodium has a high atomic number than molybdenum. The higher the atomic number, the more Bremsstrahlung X-rays that are produced. Molybdenum and rhodium K characteristic X-rays have energy corresponding to their respective K-shell electron binding energy. Things have been covered. I don't see them very well. Okay. So all currently manufactured mammographic systems have target filter combinations of molybdenum. Many are also equipped with molybdenum, rhodium, and others have tungsten, rhodium, tungsten, molybdenum. So all these can come within the same machine. And on the right, you can see that different breast thicknesses can be used with different target filter combinations. Like breasts of 0, if they are compressed, if a breast is compressed, compression thickness is 0 to 2 centimeters. Then molybdenum is enough for that. And the kilovolts peak, you can use 24. 3 to 4 centimeters, again, molybdenum, and the kilovolts peak, you can use 25, 26. 5 to 6 centimeters, molybdenum, rhodium. Now we are tending to large. So the peak is 28. 7 to 8 centimeters, molybdenum, rhodium, with a peak of 32. 7 to 8 centimeters after compression, rhodium, 30 kVp and above. So 30 to 8 centimeters. I don't know whether we have such breasts here. Focus spot size. Size of the focus spot is an important characteristic of mammo because focus spot size determines the spatial resolution. I told you that in conventional radiography, if you want a high resolution image, you always choose a smaller. Even in mammography, you have two focus spots. The one of 0.1 millimeters and another of 0.3 millimeters. So, and these focus spots are made very small to improve spatial resolution in mammography because that's where we need it most. Imaging of microcalcifications requires small focus spots. Mammo X-ray tubes usually have stated focus spot sizes, large and small, of 0.3 millimeters and 0.1 millimeters, respectively. The smaller, the better. The shape of the focus spot is also important. Normally, circular focus spots are desirable, although rectangular shapes are very common. But in mammo, we need round focus spots, or circular focus spots. To obtain a small focus spot and enough intensity over the entire breast, tubes are tilted, which we call the line focus principle. Nabunya Fatia, mute your microphone. Nabunya Fatia, mute your microphone, please. If you are to look at the mammo machine, the overhead thing, it has an X-ray tube which is tilted a bit. There is a tilt in that X-ray tube. The breast is here, but there is a tilt in that X-ray tube. The anode can be here, and maybe the cathode is there. So there is a tilt. That X-ray tube is normally tilted by an angle of about 6 degrees in order to achieve smaller focal spots as required, and also to do what? To achieve a line focus principle, as we are going to see. So that tilt is what I've been talking about. This X-ray tube is tilted a bit such that you can achieve this line focus principle, which goes, it has to be parallel to the chest wall, like that, such that we achieve or we have a uniform intensity all across the breast, uniform intensity of radiation all across the breast. The cathode is positioned to the chest wall. When you look at this X-ray tube, you realize that the cathode is on the patient side and the anode is in front of the patient, isn't it? This is the cathode and this is the patient. And the anode is on this side of the patient. So the cathode is always positioned to the chest wall. This is because of what we call Hill effect. This is because of what we call Hill effect. Now, the Hill effect is like this. If we have an anode like this, and we have a target in there, and we have a beam of electrons coming to this target, and let's assume a position here that let's assume that the X-rays are going to be produced at this point here. X-rays which traverse, okay, these X-rays as they are coming out of the target, they are going to traverse different thicknesses of the target. They are going to traverse different thicknesses of the target. Now, let me ask you one question. Which of these three X-ray photons has traversed the longest distance in the target? You can tell me the answer. Okay, let me label them. This is 1, 2, and 3. Which of them is traversing the longest distance in the target?
It is the third one.
So it is the third one which is traversing. I was saying that the third one traverses a longer distance than 2 and 1. So you don't expect these photons to have the same energy when they exit the target. The 3 will have less energy than the second and than the first. So when these radiations go to the patient, that means one side is going to be less exposed than the other. If this beam was to fall on the patient, this side which is on the anode side is going to be less exposed than the side which is on the cathode, than the side which is on the cathode side. So the cathode side produces more photons, like in terms of number and more energy, whereas on the anode side, few photons and less energy. So that's why always the chest wall is positioned on the cathode side, because the chest wall is thicker than the nipple. The chest wall side is thicker than the nipple side. So we want more intensity and more energy to penetrate the chest wall side than what we get on the nipple side, such that you can have a uniform image in the end. That is what we call Hill effect. Understood? Is that clear?
Yes, sir.
Yes, sir.
Yes.
Okay. Continue. Okay, let us look at filtration. Low KVP used for mammo tube window should not attenuate the X-ray beam. Because we are using low KVPs in mammo, we don't want the tube window to actually attenuate. With the inherent filtration is undesirable in mammo. The inherent filtration is undesirable in mammo. Let the filtration be done by the added filters itself, because if the inherent filtration is a lot, then you add in the added filtration. In the end, you're not going to have photons. So mammography tubes are designed in such a way that the inherent filtration is almost eliminated. So that means that the materials designed, that are used to design mammo tubes are somewhat different from those used for conventional tubes. So dedicated mammo tubes have either beryllium window, which is about a 4 or in terms of atomic number, and or a thin borosilicate glass window. The proper type and thickness of X-ray beam filtration must be installed. That is the biomedical engineering work. They must install the proper type and thickness of filters in the tubes. If tungsten target tube is used, it should have a molybdenum or rhodium as a filter. These filters are to reduce the higher energy Bremsstrahlung X-rays by suppressing using KH. It is suggested that 50 micrometer rhodium, which is having atomic number of 45, is a better filter for imaging thicker and denser breasts when the tube target is tungsten. Yeah, the internet is slowing down. The slides this side take long to come. That's why I'm pausing a bit to wait for them to appear. They might be appearing that side, but this side, no. Okay. Emission spectrum from a tungsten target X-ray tube filtered by molybdenum and rhodium are as shown. These are the spectrum from tungsten target filtered by molybdenum and rhodium. Of course, whenever you see suppression at around 20 kiloelectron volts, that is molybdenum. Suppression at about 24 kiloelectron volts, that is rhodium. Using a filter of the same element as the tube target is to allow the K characteristic X-rays to expose the breast while suppressing the higher and the lower Bremsstrahlung X-rays. The unfiltered molybdenum beam, which is shown in A, has a prominent characteristic X-ray emission and substantial Brems emission. You see, this spectrum has not been filtered out. That's why you don't even see any KH somewhere. So it shows you the prominent characteristic X-rays and also the substantial Brems emission. The molybdenum filter has its K absorption edge at the energy of the K characteristic X-ray emission, shown in B. So it has a K edge around 20. The combination of molybdenum target filter results in a spectrum with the suppressed Brems and the prominent characteristic X-ray emission. So remember, the spectrum was like this. All these low energetic photons have been removed, and also the high energy have been suppressed. They have been suppressed. So if molybdenum targeted tube is used, then molybdenum filtration of 30 micrometer or rhodium filtration of 50 micrometer is recommended. These combinations provide molybdenum X-rays, molybdenum characteristic X-rays for imaging along with the suppressed Bremsstrahlung X-rays or Bremsstrahlung emission spectrum. If a rhodium target X-ray tube is used, it should be filtered with 25 micrometer rhodium. This combination provides a slightly higher quality X-ray beam of greater penetrability. The use of rhodium as a target or a filter is designed for thicker or more dense breasts. The Hill effect, I already talked about it. The conic shape of the breast requires radiation intensity near the chest wall to be higher than at the nipple side to ensure uniform exposure of the image receptor, forming a uniform image. This is accomplished by positioning the cathode to the chest wall. However, compression achieves a near uniform thickness of the breast. When this breast is compressed, almost the breast becomes of a uniform thickness. But of course, the breast cannot become as thin as the nipple. Again, when you look at the top of the breast, the nipple is still conic there. So, of course, we achieve a uniform thickness for the greater part of the breast, but the nipple remains in air. So, for it, you cannot compress the breast to reach the nipple size. That can't be possible. Vigorous compression. Now we go to compression. What is the importance of compression? Compression is very important in mammography. Vigorous compression offers several advantages. Compressed breast is of a uniform thickness. Therefore, the response of the image receptor is uniform. Tissues near the chest wall are less likely to be underexposed, and the tissues near the nipple are less likely to be overexposed. This is the first advantage of compression. You're making the breast to be of a uniform thickness such that you can have a uniform exposure all throughout the breast. At the nipple is a problem. When vigorously compressed, the tissue is brought closer to the image receptor and the focal spot bra is reduced. Take an example. We have this breast here. It is not compressed. Some tissues, like for example, at this particular level, are far away from the image receptor. Even this may be solid tumor here, is somewhat far away from the image receptor. And whenever something is far from the image receptor, we get what we call magnification. And the magnification results into what we call focal spot blur of the images. So when you compress the breast, it's like you're bringing most of its tissues closer to the image receptor, and even if there was some maybe solid tumor somewhere, also becomes closer or comes closer to the image receptor. So you reduce on the focal spot blur, and the image becomes sharper. Does angiography only deal with the breasts? Salome Faith, do you know what angiography means? Yes, it is a machine designed specifically to image breasts. Did you want any other machine, or it seems like I'm offending you by always talking about the breast? What is the problem with it? It is designed for the breasts, not any other part. Okay.
Yes, I wanted to know something about compression.
Yes.
Now we are dealing with the breast which could be having a problem, and you want to find out that problem. And here you are telling us about compressing it. Now, assuming there is a mass which is painful in that inside that breast, how do you accommodate it? Because compressing it again would bring more pain to the patient. I'm
I
just trying to
understand
look at
your
it like.
I understand your point, but you
Yes.
don't compress to kill. You compress to a certain level, to a certain amount of compression force, not to cause more pain. Of course, a patient who has pain in the breast, when you compress, she will feel that pain, but don't compress too much to the extent that the patient starts to fight because it's feeling too much pain. So that's why I said that mammography should be like, if you're going to work with mammography, you should at first work with an experienced person to learn what amount of compression force is really required for a person that is in pain and a person who is not in pain. Chirama, have I answered you? Okay, so when vigorously compressed, tissue is brought closer to the image receptor and the focus spot bar is reduced. We have finished that. Compression also reduces absorption bra and scatter. Whenever the beam goes through a bigger object, the higher the probability that there will be a lot of interaction and scatter. Remember in convention when I was talking about compression devices, where we had a man lying on the table with a big stomach, and then they placed a compression device on the stomach to try to reduce on the thickness of that stomach, such that we reduce on the scatter. So the same thing here. A breast can be large, but when you compress it, it's like you're reducing on its thickness such that the scatter is reduced a bit, because scatter deteriorates image quality. You know that very well. All mammo systems have a built-in stiff compression device that is parallel to the surface of the image receptor. This is an image receptor where the breast has been put. Can be called the breast support or the image receptor itself, because that's where that detects radiation and forms an image. Vigorous compression of the breast is necessary to attain the best image quality possible. To attain the best image quality possible. Compression immobilizes the breast and therefore reduces motion bra. This is another advantage. It has like 5 advantages, and you need to know them because I asked them. Compression immobilizes the breast and therefore reduces motion bra, because mammography is performed when the patient is standing. On special occasions, performed when the patient is sitting, for example, patient who cannot walk, there is always a chair in mammo rooms where the patient can sit, can be adjustable. It is adjustable, and then the patient moves up to the level where the breast can be positioned. So remember, when you're standing, you will never stand still like an electric pole. It's not there. Even if you're standing, you're always wobbling around, trying to balance yourself and remain still, but you can never be still. You're always standing. So when the patient is standing and you have put a breast on the breast support, the breast will always be moving around. We don't want that. I was talking about motion. When you're standing, you can never be still. And if the breast is not compressed and you're positioning it on the breast support, it will always be moving around. If you image, when the breast is moving around, you're going to get motion bra artifacts in the final images, and we don't want that. So we compress the breast also to immobilize it, such that it remains in one position and then imaged. Also, compression spreads out the tissue. You know, tissues are overlapping over each other. So when you compress it, the tissues spread across the image receptor, and then they can be imaged and you see them independently without overlap. So it spreads out the tissue and thus reduces superimposition of tissue structures. It results in thinner tissues and therefore less scatter and improved contrast resolution. That is another advantage. You compress a breast, most systems now use moving grids with the ratio. Most mammography systems now use moving grids with a ratio of 4:1 to 5:1. I think you still remember these ratios. Focused to the SID to increase image contrast. The grid frequency can be about 40 line pairs per centimeter for moving for the moving grid. Use of grids does not compromise spatial resolution, but it does increase the patient's dose. You remember that? Using grids does not compromise spatial resolution, but it does increase the patient's dose, because where there are grids, there is more absorption. And if more photons are absorbed, it means that very few photons are left to reach the image receptor, which can create noise in the final images. So in order to counteract that, you must increase on the technique such that you have more photons reaching the image receptor to form the image that you desire. And when you increase on the technique, you increase the patient's radiation dose. And of course, it is still low. A unique grid that has been developed specifically for mammo is the high transmission cellular grid. It looks like a beehive, like the way that beehive is designed. Those cells in the beehives are designed where honey is kept. Very high transmission cellular grid produces scatter radiation in two directions or dimensions rather than a single direction, like what we saw with the pyro grid. Does breast compression applies to men too, because they have smaller breasts? I don't know, because they have never seen a man going for mammography, but I've seen men with breast cancer. However, I don't know whether they have ever gone through mammography examinations. So I'm not sure. You can find out. So we go to automatic exposure control. This one I've already given you a brief about it. This is a device. It is actually a detector also. Why do moving grids continue moving even after the exposure has ended? It is just the mechanism which does that. They slow down as after the exposure has ended, but it has no any impact on the image or exposure. It's just the mechanism. So the automatic exposure control is a device that terminates exposure when the desired amount of radiation has reached the image receptor. If the system has automatic exposure control, that means it can limit you on some of the factors that you can feed into the machine. Most of the things it is going to do them automatically on its own. So it is designed to measure not only the X-ray intensity at the image receptor, but also the X-ray quality. So it is positioned below the image receptor to minimize the object to image receptor distance and to improve the spatial resolution. It is normally put below the image receptor. So when radiation is going through the breast and through the detector, it can reach this automatic exposure control. This AEC will read the amount of radiation during exposure. When the desired amount has been reached, then it terminates the exposure. Because for it is calibrated in such a way that if a certain amount of radiation has been reached, that amount is enough to create the desired quality of an image. Therefore, it terminates the exposure after that value has been reached. So it is either an ionization chamber or a solid state detector. Okay, magnification mammography. Sometimes we may require images that are magnified a bit, and that is the end of mammography. Let me welcome the questions about this. Questions?
How about the sit or stand? So mammography does not apply on them.
How about what? I didn't get the question.
Like a patient who cannot sit and who cannot also, I mean, like she cannot sit, but is just remains lying down. And like the machine is designed is for a patient to sit or to stand. But now we are saying, what about a patient who cannot sit nor stand?
Then that patient cannot qualify for mammography because it needs you when you're sitting or when you're standing. So if you are bedridden, then there's no need for mammography because there's no way it's going to be done. There is a lady who asked, but I did not get the question very well. Any other question?
Sir, excuse me.
Yes.
I think the lady who was asking that mammography only deals with breasts.
Yeah, I think I've already answered that.
Yeah, that's the question.
Salome Faith asked that question, and I answered. It is only designed for breasts, not any other. It is for breasts. Nalia Justin, what's your question?
Excuse me, sir.
Yes.
It's Mr. who asked you later last week about the size of the breast, if it has any negative impact, and I think I have got the answer. Just to add on that, I'd also wanted to find out, because this seems to be it's a good lecture actually. It's been a good one, and I think our sisters out there, I guess they must have picked up something out of this. And you talked about is it annual breast examination for the ladies? I don't know whether we advise them to go for this. Is it screening mammography, where they say it is performed on asymptomatic feminines, and then the other one is also self breast examination applicable, like for the ladies? Can they be doing that as a way of like doing self-screening?
I think I also gave you the difference. Self-breast examination is for you to monitor your breast, like maybe thickening of the skin, or to feel whether there is a lump inside or anything that is about the breast that is strange to you. That is self-breast examination. Things that you can touch or you see by your eyes, that is self-breast examination. But screening is about detecting something that you never expected, because if you have microcalcification of the breast, even if you touch your breast trying to look for lumps, you will never feel the microcalcification. That's why I say that self-breast examination is not sufficient enough, or is not enough for you to know that you are okay or not okay. So in order for you to be at peace, you also need to do the screening to see whether there are some microcalcifications that are growing without your knowledge. So breast screening can be performed in any facility that has a mammo machine. They can do both screening and also diagnostic. Have I answered you?
Yes, so you've answered me. I just have one. It sounds a little bit funny, but it is just for learning. Purposes. I guess most of us have seen this on social media where they say, "Is it men should suckle the women's breasts because it does reduce the risks of breast cancer." Maybe some light on that, sir.
Not meant to suckle the women breast, but it's about women who do not want to breastfeed. You are prone to getting breast cancer because when you give birth, the breast goes into a certain mode that it has to be sucked by a baby. If you do not do that, if you don't do that, then you are prone at getting breast cancer. So when you give birth to a baby, please, as a lady, breastfeed your child, or breastfeed your infant. Is it called an infant? I don't know. Breastfeed your baby to maybe at least 6 months. If you don't do that, then the probability for you getting breast cancer also keep on increasing. But not men to suck, because when you as a man, when you suck, what are you going? Is there anything that comes out of the breast when you suck it? Nothing. Maybe when the woman, your wife is breastfeeding and also you suck, maybe you can suck some milk. But who does that?
Okay, sir. But at times we are also caught up between maybe between the thorn and a hard rock, in that there are some mothers upon giving birth, you realize a mother does not have breast milk. So definitely putting an infant on the breast almost carries no much importance. I don't know how we will deal with that.
Just a moment. Just a moment. I'm talking to someone here. Then when I come back, please, we're going to repeat your question. Just a moment. The person who was asking.
It was Miss Sir. I would say,
Nabunya Fatia, mute your microphone, please. Nabunya Fatia.
well, sir, it was me. It was me trying to put up something across, and I did say that the essence of breastfeeding is basically, the essence of putting a baby on the breast after birth is to initiate the process of breastfeeding, and also, of course, to encourage the baby feed. But at times you realize some mothers, I don't know for what reason, or one reason or the other, you realize they do not have breast milk throughout their time of breastfeeding, and that's why they opt for cow's milk. So, and yet breastfeeding is one way that is being encouraged, because it does help reduce risks of breast cancer. Now, in that circumstance, because definitely you can't put the baby on the breast, because there will be no breast for the baby to suckle, it means that mother cannot breastfeed. How would we help such mothers?
Now, such mothers, that is actually a reality, that if a person doesn't really breastfeed well, the chances are high that you will contract breast cancer. So it is someone's nature in this case, and we have nothing to do about such a kind of nature. yes, that person has no breast milk, is not breastfeeding the baby. Also, the chances are rising that that person will get breast cancer, but there's nothing to do about that. You just have to you just have to be put in prayers that you don't get the breast cancer, but totally there is nothing to do about that. If that person has failed all the if it has really failed, you know, to bring breast milk, there are so many things that they tell you to take, medicines and what to enhance it. And if the person has done all that and it has failed, then there is nothing to do about that. I don't know whether I have answered you, but that is the reality. Because a cancer to come, no one calls a cancer. And there is nothing that you're going to do to stop a cancer from coming. So, nothing to do about that.
Okay, thank you so much.
While talking about magnification mammography, you said that a supporter is needed in which the breast is put. On which the breast is put, it is put on the top of the breast support, so that it is removed from direct contact with the image receptor. So my question is, what's the essence of removing the breast from direct contact with the image receptor? I told you that when something is far away from the image receptor, it becomes more magnified in the image. This is what I drew for you. If the breast is here and the lesion is here, because of the beam divergence, this lesion here is going to cast an image which is bigger than its size. The tumor or any lesion is going to become more bigger than its actual size. That's what we call magnification. If you want something to be magnified, take it away from the image receptor. If you don't want magnification, bring it in contact with the image receptor. There won't be any magnification. Atushabe Mary, I see your hand is up. Do you have any question?
Yes, sir. I wanted to inquire about this argument going on about the breast circling. Must it specifically be a baby? Because also the breast pumps do the same, they use the same mechanism of pumping the milk out of the breast.
Yeah, breast pumping is also okay. But why would you really pump the breast? You would put the baby on your breast and the baby suckles. Why do you like to pump breasts? Anyway, yes, it also reduces the chances of getting the breast cancer because something is moving out of the breast. Have I answered you?
Yes, sir, thank you.
In terms of risk factors, those with small and big breasts, I don't know. That one, maybe you can read something about whether someone with small breasts is more risk, is more prone or less prone, I don't know. If all the imaging techniques are followed, is there no chance for artifacts that could lead to misdiagnosis? Yeah, if you follow everything to the dot, as I've said, there won't be any artifact in the final image of mammography. And mammography really has very few artifacts, unless if there is a problem with the image receptor itself. But if you follow to the dot, you won't create any artifact in the final image. All right, I think those are enough questions. Let's end here. Let's meet on Friday morning. Enjoy your evening.